A multivisceral aneurysm. This is my place. I don't have disclosure. It's a clinical case in a male about 39 years old with a historic with former smoker, umbilical neoplasty, and gastric bypass. The outpatient consultation with epigastric pain, radiation of both hypochondria plus fever. At emergency room, lab work and CT scan of the abdomen and pelvis were requests, and consultation with bariatric surgery due to story. And the bariatric surgeons think about the exploratory laparoscopy is the first, and they saw that. A great hematoma, and they put that this impression of venous thrombosis in the supramesenteric territory. After that, the patient was in the immediate postoperative period in intensive care, and the physician started the low molecular heparin, and intercurrents in Argentina have an epidemic from dengue, but the patient have dengue with normal platelets. And the intensive care requests other CT angiogram, and that is the problem. And so that this is the real problem. No dengue and no venous thrombosis. We can learn about the guidelines of the management of visceral aneurysm, and we think that the first step is determine that he has active bleeding, and we make a aortographic and don't see active bleeding, and we think that the medical management to choose the best treatment. This is the angiography. Don't see active bleeding. But after 24 hours, have the patient hemodynamic decompensations with hematocrit drop to 24, abdominal defense, and make a new CT scan, and we can see the great hematoma. And the only option was spray and open for vascular surgeon. And they make a laparotomy, and only saw a great hematoma. No active bleeding, and our conduct was that a bleeding and root of mesenteric artery, hematoma, capsule dissection, and hemostatic sponge placement, and the really problem was the patient was on anticoagulants with suspected diagnostic of venous thrombosis, and really was a rupture pseudoaneurysm of the mesenteric artery. They have a growth evolution, growth process, and this kind of follow-up outpatient vascular surgery clinic. And in the second interrogations, the patient said that a family story for aneurysm, father, aunt, and uncle. And we think that the important to determine that genetic components, and we make a orthopenic panel. Clinical significant variants of the lesions. And why is very important? We must rule out association of collagen pathology, Marfan, Ehlers-Danlos, because the behavior of this disease is different, and if the involvement of the thoracic aorta, they have a greater possibility, a rupture regardless of the aneurysm diameter. And what is the conduct? In 2 steps, the resolution of celiac trunk aneurysm and resolution of iliac artery resolution. In the first step, we resolution the iliac artery aneurysm with a customized endograph with fenestration for both hypogastric arteries, because the patient have a type 4 for iliac aneurysm. And we use Artivion, Hedra, and Heliax. We guarantee the hypogastric and the iliacs in crossing over in the first step, and second step to release aortic graft body. This final control is 30 trace control. What about the celiac trunk aneurysm? We chose about a flow diverter, and we chose about the Rivo2. And we have a selective celiac trunk catheterization. Positioning of the splenic artery, we think that the splenic artery is the most important to permanent. And we release this final control. This control about 30 days postoperative. Well, the management of multivisceral aneurysm is a challenge from vascular surgeon. PIMO's role of hereditary familial etiology. We must understand and manage of the various techniques and alternatives for this condition to determine the appropriate treatment. We need to have knowledge combined with skill in both conventional and endovascular attention. Thank you, it's my group.